This is Dr. Howard Strassler presenting the e-lecture Decision Making in Restorative Interventions, Module C, Rationale for Posterior Restoration Replacement. And this module on rationale for restoration, replacement, and repair will parallel for posterior restorations what we'll talk about for Class 3s and Class 4s and Class 5s. In fact, one of the case conferences will focus on a generalized view of evaluating restorations for their acceptability when we replace, when we repair. And there'll be readings on an article that goes through some of the ideas, concepts for that type of decision making. Besides this media site presentation, download this file in PowerPoint view, and you'll see that some notes are added to the individual slides to provide some additional insight into how the clinical decisions are made. So we're making decisions, we're looking at restorations that are present in the mouth, we're doing our clinical exam of the hard tissue, and we're evaluating a number of different things about that restoration. And what I'd like you to think about is think back to first year when you were waxing full contour restorations for function. And in your fixed prosthodontic course, conceptually, every time you place a crown, you're placing a restoration that hopefully is mimicking what Mother Nature gave us, which is the crown, an enamel crown of a tooth. And so when we look at a restoration, how it's functioning, how it's maintaining health, we're looking at a variety of different things. We're looking at the contour of the restoration, and certainly its anatomic form. Every restoration has cavus surface margins that we've marginated through our carving, through our finishing and polishing, and we're looking for the acceptability of those margins. Are the margins stained? Are they ditched? Do they have gaps between the restoration and the tooth? Are there fractures in the restoration, whether it be bulk fractures through and through in the restoration, or are there fractures at the margins leading to ditching? We're looking at recurrent caries, and keep in mind our evaluation is both clinical, using our vision of a clean, dry field with or without magnification, using an explorer to run it over the marginal areas over the restoration. But we're also looking for recurrent decay at those marginal areas and any recurrent caries that might be visible on a radiographic image. We're looking for loss of anatomic form through wear, through attrition, through fracture. In fact, many times our amalgam restorations, our metallic restorations do quite well. Our composites, as they get larger in size and form, show significantly more wear over time. The more posterior we go, the more at risk those teeth are of wear and fracture. For composites, we're looking at whether or not the restoration is still aesthetic. Has the composite picked up stain? Has it yellowed and changed color? And radiographically, we're looking for any evidence of any recurrent caries, any open margins, and we're also looking for signs of initial caries. Now let's take a look at this clinical image on the right-hand side. And what we'll notice in the mandibular first molar is that someone was trying to do minimally invasive amalgam restorations for this patient. Unfortunately, some of the pits and fissures, not restored, were still at risk of caries. Now, those amalgams could have been done minimally invasively and then the tooth covered with a sealant, and that would have provided our extension for prevention. And while the mandibular first molar shows decay into the buccal groove and a carious lesion initiating in the mesia fossa, if we take a look at the mandibular second molar, it's more obvious that while an isolated lesion was treated with amalgam, that the buccal groove, the lingual groove, and the distal groove were fissures that were highly susceptible and have become carious. And one might say, did this dentist do wrong? Did they do harm to this tooth by not doing their extension for prevention? And I would rather tell you that I'd ask the question when I see this clinical case, did the patient come in regularly for their routine recall appointments? Because certainly in the second molar and in the first molar, these carious lesions would have been picked up earlier and the restoration replaced. So we look at those reasons for restoration replacement and we build upon what we've just been speaking to. We look for marginal voids, especially look in the gingival third in areas that can't be repaired. We're going to look at inadequate anatomic form, convexities, concavities, over-contouring. We'll look for gingival overhangs, those that can be picked up with our explorer, with our periodontal probe, that we can see visually. We'll look for gingival overhangs that are radiographically apparent. And look at the periodontium. While we're focused in on doing a hard tissue exam, the periodontium may give us a pathway to understand how the defective restorations leading to periodontal disease. Look for signs of localized inflammation, bleeding upon probing, food impaction, food retention. That's part of a periodontal pathology that's being contributed to by that defective restoration. We look at occlusion and loss of occlusal function, look at marginal ridge discrepancies, and see whether or not the patient is retaining packing food between the teeth. Look for proximal contacts, especially in the posterior. That our evaluation is more than just a look and a see, but really running floss between the teeth, running the explorer over the restoration in tooth to look for discrepancies. We can have reasons to replace restorations because of significant over-contours on the facial, lingual, proximal surface. We look for recurrent caries that's evident with an explorer or just visualizing color changes under a marginal area that may be recurrent to carie. We're looking at marginal ditching, and in fact we'll look at some of the research that supports how we make a decision that marginal ditching, which by definition is the gap between the cavo-surface margin of the preparation and the restorative material. Either the restorative material is fractured away, it's corroded away, whatever it is, it's lost, and when we see ditching greater than 0.4 of a millimeter, either it's carious that's obvious, that there's recurrent decay, but in those cases we know that those are caries susceptible areas. When we evaluate the proximal contact, look to see if it's too heavy. Can you run floss between the teeth or not? Is it too light where the floss just drops through, or is it not even present that we can see light through that contact? While in the anterior, not very critical. In fact, over 35% of anterior teeth have some spacing. For a posterior tooth, in function, you'll see food impaction, food retention. You need that proximal contact. And look where the proximal contact's located. Is it in the correct location? Does it have the correct size? When restoring teeth with direct restorative materials, typically the proximal contact of the restoration is wider than what was there normally. And think about this. Replacement of existing restorations accounts for 75% of all the operative treatment we provide. In fact, when you're in the clinic treatment planning patients, the majority of your patients won't have initial carious lesions for the treatment that you'll be offering, that you'll be replacing existing restorations due to some of the things we just spoke about and spoke to, and we're going to see some examples. And as I mentioned earlier in this e-lecture, We'll be looking at examples throughout our decision and treatment planning e-lectures. The most frequent reason for replacement of a restoration is secondary caries, and we can look at the evidence and the data that supports that statement. Dr. Major, back in 1981, did a benchmark study where he looked at placement and replacement of restorations. He surveyed 87 private practitioners who filled in a survey of close to 5,500 restorations that they placed. Now, this was 1981, where amalgam was our predominant restorative material in the posterior. And so they looked at 74% of the restorations that were placed were amalgam, 26% were composite resin. Of these 5,487 restorations that were reported on, 71% of the amalgam restorations placed were replacements of existing restorations. 79% of the composites were replacements. Now keep in mind, in 1981, we were just at the beginning of light curing. We were just at the beginning of major acceptance of adhesive restorations, and our composites were significantly poorer than the composites we place today. But as we look at the evidence, you'll see that these are not uncommon data points, even comparing 1981 to what we're seeing now in 2012. So what were the reasons for replacement of these restorations in this 1981 survey? Well, secondary caries was by far the highest reason for replacement of restorations. 61% of the restorations that were amalgam were replaced because of secondary caries. 9% were replaced due to poor marginal adaptation. 12% due to isthmus fracture. The restoration itself fractured. It was obvious 12% of those restorations were due to isthmus fracture. The tooth fracturing was responsible for 11% of those restorations, and 7% were other reasons. So it gives you an idea why amalgam is typically replaced and treatment planned for replacement. When looking at our earliest composite resins from the 1970s, 1960s, that secondary caries was replaced for due to 20% of the time. The restoration, discoloring, and many of the composites back in that era were self-cure, and they tended to have color changes to yellow-orange over a period of 18 months because they were self-cure due to the chemistry of tertiary amines. 40% of the restorations were replaced due to poor anatomic form, and keep in mind, back in that era, we're talking about anterior restorations, class 3s, class 4s, typically class 5s. And these earlier composites were very susceptible to wear and attrition over time. Discolored margins were replaced 8% of the time, and 20% were for other reasons. But once again, secondary caries is that highest category for replacement of restorations with composites. In another study by Nairn Wilson and his group in 1997, and once again, Dr. Major, who published the benchmark 1981 study, has been involved in numerous studies looking at and repeating this data. And here we are looking in 1997 at close to 2,400 restorations from 22 private practitioners who were surveyed. For the amalgam restorations that were replaced, 43% were due to secondary caries, 15% due to poor margins, 19% due to isthmus or bulk fracture of the amalgam. Fracture of the tooth was responsible for 11%. They added the category of pain and sensitivity as a reason for replacement. And pain and sensitivity may relate to the fact that restorations of amalgam in posterior teeth sometimes contribute to a crack in the tooth, a fracture, that when the patient bites down, the tooth becomes painful, and that's a reason for replacement. Uh, the unestheticness of amalgam, its gray, dark color, was a reason for replacement 1% of the time, and the trending now to replacing amalgam with more aesthetic restorations has been constantly on the rise, and other reasons was responsible 6% of the time for replacement and restoration with amalgam. So this 1997 study of these almost 2,400 restorations, when we looked at composite, that the data is very similar to what we saw in the 1981 study. 26% were replaced due to secondary caries, 19% due to poor margins, 4% due to bulk fracture, 14% due to fracture of the tooth, and pain and sensitivity contributed 4% of the time. Aesthetics has become a much more important criteria for replacement. Upwards of 26% of the restorations were replaced due to the fact they were unesthetic. And you might say, why this significant increase? And it's because by 1997, we expected more of our composites. In the 1970s, we really believed that composite couldn't be done in such a way that it would not become unesthetic. It was okay that the composite was stained, larger particle size fillers, and they'd pick up staining more rapidly, very hard to polish. They had color shifts due to the chemistry of the self-cure composite to yellow-orange shades. And so the expectation was composites will be unesthetic within 12 to 18 months. That was expected. But by the 1990s, the late 1980s, the composites were better, more polishable, more stain resistant, no color shifting due to the light curing. And so if we saw a composite that didn't look good, we'd ask the patient, would they want it replaced with something that looks better? In this 1997 study, glass ionomer was included. Glass ionomer was introduced to the dental profession in the late 1970s. It was a very poor material back then, but we've seen advances in the chemistry of glass ionomer to where it becomes a routine restorative for certain situations. And we know glass ionomer is a self-adhesive, ionic attraction to dentin and enamel to the calcium within the tooth. But keep in mind, for all the things we talk about glass ionomer and its fluoride release and its resistance to secondary caries, yet when glass ionomers were replaced, secondary caries was the highest reason for replacement, 26% of the time. And you might think, how can you get secondary caries adjacent to a glass ionomer which has fluoride release? And the answer is quite simple. That it's not that we don't see recurrent decay around glass ionomers, but that what we do see is that it takes longer for the carious lesion to occur. Keep in mind, when we place restorations, most of the time our initial placement is due to initial caries. These are at-risk areas, and so the areas become carious again. Poor margins 16% of the time, fracture 9%. The tooth fracturing with a glass ionomer restoration 15% of the time. Pain and sensitivity 10% of the time. Once again, is there a crack in the tooth? Unesthetic, unsightliness 8% of the time, and other reasons were 16% of the time. So what are the predictors of secondary caries? We just talked about recurrent caries, secondary caries as being the primary reason for replacement of our restorations. In fact, restoration replacement being 75% of the treatment that we offer for single tooth restorations. Well, Edwina Kidd and her group in 1995 looked at extracted teeth. They sectioned them. They looked at what was defective about a restoration and then whether or not those defects led to carious lesions, and what they were looking at what we call wall lesions. When we section the tooth, do we see demineralization along the wall or the cavity preparation adjacent to where the restoration was? And what her group found, looking at these extracted teeth to make decisions, is that if the margin was ditched, a gap between the tooth and the restoration, and it was greater than 4/10 of a millimeter, about the diameter of a periodontal probe, uh, that this greater than 4/10 of a millimeter of ditching was indicative of secondary caries. That when they looked at narrow ditching, less than 4/10 of a millimeter, that they viewed and saw in their study that that narrow ditch was not different from an intact margin, that in fact recurrent decay couldn't be predicted. They looked at marginal staining, that when we look at the enamel we see that discoloration under an amalgam, that shadowing, that darkness, that bluing of the enamel, and we say, gosh, there's recurrent decay under the enamel. In fact, it's just the enamel shining through the translucent enamel and dentin. In fact, many times in those circumstances when the tooth was prepared, the enamel was left unsupported and the amalgam was right up against the enamel, not dentin, and you'd get shine through. So that the color of the enamel was irrelevant to making a diagnosis of bacterial infection and secondary caries. In fact, their conclusion and their predictors of secondary caries for amalgam was narrow ditching of margins and color change should not trigger decisions to replace amalgam restorations. Now keep in mind, clinically, we'll look at the tooth and examine it, but we'll also look at radiographs to help make that decision. And so when we talk about restorative interventions on existing restorations, when we see acceptable restorations, we're going to reevaluate them, do active surveillance. Nothing lasts forever. The durability, the longevity of restorations is dependent upon many different factors, including patients' frequent recalls, how they care for the restoration, how you placed the restoration, how you prepared the tooth, the restorative material used. When you do your examination, note suspicious areas for reevaluation. Make a note in the chart and then go back to it that you're going to look at that a little bit more closely. In fact, when you look at this lower image, these are sealants that were placed 10 years ago. They're holding up quite well, but in order for these sealants to survive, and you can see premolars show a lot less wear than molars and are doing quite well, but the first molar, first permanent molar, which takes a lot of occlusal force, that these sealants have been lost in increments, and now we have very little sealant over this tooth. It may be time to replace this sealant. Replace and repair of sealants is something that we need to do on a regular basis. What if we do our examination and we determine that the existing restoration is defective? If it's defective, we consider complete replacement, whether it be amalgam or composite, which means removing the entire restoration within the tooth preparation. If it's just an isolated area that is defective and the rest of the restoration is intact, to maintain pulpal health, just do an isolated repair of that restoration with the restorative material. Our preparation extension is going to be dependent upon the extension of the defect of the pathology. Now, you will have faculty members and dentists who have the philosophy all restorations need replacement because you never know what's underneath it. In fact, you make that decision as you're taking out the restoration as to how to proceed based upon having more information as you're removing the restoration. And so let's take a look at some. When we look at the image of what we saw earlier, we can see that there's initial caries in the buccal groove. There's recurrent decay around an initial amalgam restoration. We see initial caries in the pits and fissures in the buccal groove and lingual groove of the second molar. And that one could say this isn't recurrent caries around the amalgam on the mandibular second molar, but rather initial caries because the preparation wasn't extended. We can see loss of anatomic form on this MOD composite resin on tooth number 30. Let's take a look at the amalgam ditched margins on the mandibular second premolar on the facial. These defective margins are very obvious, and this restoration needs replacement. We're not doing it due to shadowing, but rather this ditch is greater than 4/10 of a millimeter. Or for this restoration, we see poor contour between the Class 2 MO amalgam restoration on the maxillary first permanent molar adjacent to the premolar, and the patients had a chief complaint of packing food between the teeth and that the gingiva bleeds very easily when flossed. We might see a marginal void as we see on this gingival aspect of the composite restoration on the first premolar. In fact, around the composite we see shadowing and darkening, and unlike amalgam where discoloration is not indicative of anything, on the composite this shadowing is indicative of recurrent decay. When we look at the maxillary molar and we look at the lingual margin, we see a ditched amalgam margin. That margin is less than 4/10 of a millimeter. We, in all probability, wouldn't replace it unless we see recurrent decay in other areas. In fact, in the mesial buccal cavo-surface margin of the Class 2 amalgam on that maxillary first molar, I can get an explorer into this area and it's a larger ditch. I'm not doing a repair, but in fact replacing this amalgam restoration. So we see loss of anatomic form, we see marginal staining, and perhaps recurrent decay around this long-lasting composite restoration that is documented being in place for 18 years. We can see ditching on the amalgam margin on the mandibular first molar, but this ditching is less than 4/10 of a millimeter, and this amalgam is acceptable even though it does look very unaesthetic and it doesn't have perfectly intact margins. Sometimes we see amalgam fracture and function. When amalgam fractures, any restorative material fractures, we absolutely need to replace it. It means that the restoration moved, and we'll see percolation of bacteria, saliva down that interface, and you'll see recurrent decay. You don't wait to replace it, you replace it immediately. In fact, for this distal occlusal amalgam on the mandibular second premolar, we can see marginal ditching on the facial cavo-surface margin, and in fact we can see it's larger than 4/10 of a millimeter. In fact, if I place an explorer in this large gap, I'm going to get debris out of there. It's going to be soft and sticky, indications of secondary caries. We saw that ditched amalgam margin being greater than 4/10 of a millimeter as being a reason for replacement. Defective margins, and we need to evaluate anatomic form, marginal areas, function, sensitivity, pain upon biting, all reasons for restoration replacement. In this case, the maxillary first molar has wear of the mesiobuccal cusp, loss of anatomic form, and we see discoloration around the cavo-surface margins that are shadowing the tooth, and for composite that's typically indicative of secondary recurrent caries. So let's review the reasons for restoration and replacement. Marginal voids, especially in the gingival third, that can't be repaired. Inadequate anatomic form. Gingival overhangs. Any discrepancy that contributes to periodontal pathology in the restoration. Marginal ridge discrepancies. Loss of occlusal function are all reasons for restoration and replacement. Restorations that are over-contoured on the facial, lingual, proximal surface. The presence of recurrent caries. For amalgam, marginal ditching greater than 4/10 of a millimeter that are either carious or we consider caries susceptible. Poor proximal contact where the contact is either too heavy or too light or not present, or it has an improper location and size. When we're making decisions in treatment planning restorations for posterior teeth, class 1s and class 2s, We need to start with a correct diagnosis, and then we'll select the material and restorative techniques that fit that given circumstance. And we have choices of the materials and techniques. It's not a one-size-fits-all decision. You've just been listening to and watching Decision-Making and Restoration Interventions, Module C, Rationale for Posterior Restoration Replacement.